There's a television show now about MASH units. Everyone loves it. It's funny, they tell me, charming, full of wisecracks and hijinks and brave doctors saving lives while cracking jokes. I can't watch it. Tried once, had to turn it off after 10 minutes. They got the tense right at least, and the helicopters. But everything else, the laughter, the clean uniforms, the way everyone seems to have time to stand around talking, none of that was real. None of that was what it was actually like. My name is Margaret Sullivan, Captain, Army Nurse Corps. I served with the 8076th Mobile Army Surgical Hospital in Korea from June 1951 to August 1952. 14 months that felt like 14 years. 14 months that I'm still trying to process 22 years later. I'm from a small town in Pennsylvania, Lancaster County, farm country. I was the oldest of 4 daughters, and I was always the responsible one, the one who took care of everyone else. Becoming a nurse felt natural. Taking care of people was what I did. I graduated nursing school in 1948, worked at a hospital in Philadelphia for 3 years. Good work, important work. I helped people, saved lives, made a difference. But when the Korean War started, I felt like I needed to do more, needed to serve. So I joined the Army Nurse Corps in early 1951. My mother cried when I told her my father, who'd served in World War II, he understood. Someone has to go, he said. Might as well be someone who volunteered. They sent me to Fort Sam Houston in Texas for military training. 6 weeks of learning how to wear a uniform, how to salute, how to march. Then to a field hospital course where they taught us about treating combat casualties, about working in austere conditions, about triage. Triage, that was a new word for me. In civilian hospitals, you treat everyone. Everyone gets care, everyone matters. But in combat medicine, triage means making choices, deciding who gets treated first, deciding who might not get treated at all. They explained it clinically, 3 categories: immediate, delayed, expectant. Immediate means treat now or they die. Delayed means they can wait. Expectant means they're going to die anyway, so don't waste resources on them. I remember thinking I could never do that. I could never decide to let someone die. I was naive. War has a way of burning away naivety. I shipped out to Korea in May 1951. The war was a year old by then, settled into a grinding stalemate. The front lines barely moved, but the casualties kept coming. Thousands of boys getting shot, blown up, torn apart in a war that had no clear purpose except to contain communism and prevent World War III. The 8076th MASH was stationed near Wonju, maybe 20 miles from the front, close enough to get casualties quickly, far enough back to be relatively safe from direct attack. Relatively. Nothing in Korea was truly safe. The unit was a collection of tents, surgical tents, ward tents, mess tents, supply tents, everything portable, everything ready to move if the front shifted. There were 42 of us at any given time, doctors, nurses, corpsmen, support staff. We worked 12-hour shifts, sometimes longer. Sometimes we worked for days straight when casualties were heavy. My first day, they assigned me to the pre-op tent. That's where the choppers brought the wounded, where we did initial assessment and stabilization before surgery. The chief nurse, Major Catherine Williams, showed me around. "You ever seen combat wounds?" she asked. "No, ma'am." They're different from civilian trauma, more violent, more catastrophic. You'll see things you can't unsee. She paused. "How long you been a nurse?" 3 years, ma'am." "Good. You'll need that experience. The boys we get here, they need the best we can give them. No room for mistakes, no time for hesitation. You understand?" "Yes, ma'am." She looked at me, really looked at me, and I saw something in her eyes. Exhaustion, resignation, something worn down and hollowed out. "You will," she said. "Soon enough." I reported for my first shift that evening. Quiet night, they said. Only 2 choppers expected. Easy introduction. The first helicopter landed at 2100 hours. I heard the blades before I saw it, that distinctive whump, whump, whump cutting through the night. We rushed out to meet it, stretchers ready. They unloaded 4 casualties. The corpsmen carried them into the tent, shouting vital signs, describing injuries. I moved to the first stretcher, and that's when I understood what Major Williams had meant. The soldier on the stretcher had been hit by a mortar. His left leg was gone below the knee, the stump wrapped in blood-soaked bandages. His right arm was mangled, barely attached. His abdomen, there was a hole in his abdomen, and I could see things inside that should never be visible. He was 19 years old. I saw his dog tags when I checked for identification. 19, and he was conscious, looking at me with terrified eyes, trying to speak through the pain and shock. "Am I going to die?" he asked. "Please, am I going to die?" I didn't know what to say. Didn't know if he would or wouldn't, so I said what I'd been trained to say. "We're going to take good care of you. You're in good hands now." We rushed him to surgery. I never found out if he made it. There wasn't time to find out. The second helicopter was already landing, and there were more wounded, and my shift had just begun. You fall into a rhythm in a MASH unit. Not a comfortable rhythm, but a routine nonetheless. Helicopters bring casualties. You assess them, triage them, stabilize them, send them to surgery or to the ward, or, if you're lucky, straight to evacuation for treatment at a rear hospital. If you're not lucky, you send them to the morgue tent. The casualties came in waves. Sometimes we'd go days with only a handful. Other times, when there was heavy fighting on the line or a big push or an ambush, they'd come nonstop. Dozens in a day, more than we could handle. July 1951 was bad, really bad. The Chinese launched a major offensive, and suddenly we were getting slammed. 20, 30 casualties a day. The surgical teams worked around the clock. We converted the post-op tent to a second surgical suite just to keep up. I worked 18-hour shifts. Sleep when you can, eat when you can, work until you can't stand anymore, then drink coffee and work some more. The wounds were horrific. Gunshots, shrapnel, burns, blast injuries, boys with holes blown through them, boys with limbs barely attached, boys with faces torn apart, guts spilling out, bones shattered into fragments, and we were supposed to save them. We're supposed to fix what war had broken. Most of the time we did. The survival rate at MASH units was incredible. Something like 97% of soldiers who reached us alive would survive. That's what they told us anyway. That's the number they used to justify everything. But that number doesn't account for what they survived as, doesn't account for the amputations, the permanent disabilities, the faces that would never look the same, doesn't account for the psychological damage, the trauma, the knowledge that they were 19 or 20 years old and their lives were already ruined. I learned to be efficient, learned to assess quickly, treat aggressively, not waste time on emotion or hesitation, learned to insert chest tubes to pack abdominal wounds, to control bleeding with my hands when there wasn't time for anything else, learned to decide who got treated first, who could wait, who was expectant. That last category, expectant, that's the one that still haunts me. The ones who were too far gone, too badly injured, who wouldn't survive even with immediate surgery. We'd give them morphine, make them comfortable, and move on to someone we could save. It made sense. Mathematically, logically, it made perfect sense. Use your limited resources on patients with a chance. Don't waste time on hopeless cases when you could be saving someone else. But they were people. 19-year-old kids who'd been healthy and whole that morning and now were dying on a stretcher in a tent in Korea. And I was the one deciding to let them go, Private James Cooper from Tennessee. That was the first one I triaged as expectant. He'd been hit by artillery, multiple penetrating wounds to the chest and abdomen, bilateral tension, pneumothorax, massive internal bleeding, shock. His blood pressure was dropping despite fluids. His breathing was gasping and wet. "We need to get him to surgery," the corpsman said. I looked at Cooper, looked at his injuries, looked at the other casualties waiting, the 2 boys on stretchers who had survivable wounds if we got to them quickly. Made the decision. "Expectant," I said. "Give him morphine. Make him comfortable." The corpsman stared at me. "Captain Dash Dash, do it. We have to move." I turned away, moved to the next patient, did my job, saved the ones I could save, and tried not to think about Cooper dying behind me. He lasted 20 minutes. I know because I checked his time of death later. 20 minutes of struggling to breathe, probably terrified, probably wondering why no one was helping him. Because I'd decided he wasn't worth helping. That's what expectant means, not worth the resources, not worth the time. I threw up after my shift, first time but not the last. Went behind the supply tent and vomited until there was nothing left. Then went to my tent, lay on my cot, and cried. Major Williams found me there, sat down beside me, didn't say anything for a long time. "First expectant?" she finally asked. "Yes, ma'am. It gets easier." "Does it?" She didn't answer, and I realized that was the answer. It doesn't get easier. You just get harder. August 1951. We got hit with a mass casualty event. Ambush on a supply convoy right near the front. 37 casualties, all arriving within 2 hours. 37. We had 2 surgical tables, 4 surgeons, 6 nurses, dozens of corpsmen, and 37 boys who needed immediate care. It was chaos, controlled chaos maybe, but chaos nonetheless. Every available space became a treatment area. The pre-op tent, the post-op tent, even the damn mess tent. We were doing procedures everywhere. Chest tubes, tracheostomies, amputations, just trying to keep people alive long enough to get them to surgery. I worked in the pre-op tent doing triage, directing traffic, trying to decide who went to surgery first. The decisions came fast, too fast. No time to think, no time to second guess. Just look, assess, decide, move on. Immediate, delayed, expectant, immediate, delayed, expectant, immediate. The expectants we put in the corner, gave them morphine, held their hands if we had time, moved on. We didn't have enough staff to stay with them. They died alone in the corner while we worked on others. 7 men I designated as expectant that day. All of them died, ages 19 to 23. All of them probably could have survived if we'd had more surgeons, more time, more resources. But we didn't, so they died. One of them, I don't remember his name, never saw his dog tags. He grabbed my arm as I was walking past. His grip was weak but desperate. "Please," he whispered, "don't let me die. Please." "I'm sorry," I told him. "I'm so sorry." I pulled away, went to the next patient, did my job, and he died behind me, probably still asking for help that never came. That's when something inside me broke. Not dramatically, not all at once, just a quiet fracture, a small crack in the foundation. I felt it happen, felt something fundamental shift. I kept working, worked for another 10 hours straight, saved 15 men that day. 15 lives preserved because I made the right decisions, because I triaged correctly, because I was efficient and cold and didn't waste time on lost causes. 15 saved, 7 dead. That's a good ratio. That's a success. But I couldn't stop seeing the man's face. Couldn't stop hearing him ask me not to let him die while I walked away. The surgeons were heroes. Everyone said so. They worked miracles, saved lives, did the impossible day after day. They got medals and commendations and respect. But we nurses, we were the ones who decided who got to see a surgeon at all. We were the ones who decided who lived and who died before they ever reached the operating table. No one wants to talk about that part. No one wants to think about the logistics of triage, the mathematics of mass casualties, the cold calculations that determine who deserves a chance and who doesn't. The corpsmen burned out fastest. Young kids, most of them, 18 or 19 years old. They'd see things no one that age should see, and they'd break. Some would stop talking, some would start drinking, some would request transfer, some just disappeared one day, AWOL, heading to the rear, unable to take it anymore. I understood. I wanted to disappear too, wanted to wake up and have it all be a nightmare, be back in Philadelphia treating pneumonia and broken bones and normal civilian problems. But I was an officer. I was a nurse. I was responsible. So I stayed, did my job, made my decisions, carried my guilt. The worst weren't the ones who died immediately. The worst were the ones who died later, the ones we saved, who survived surgery, who made it to post-op, and then died anyway, from infection, from complications, from injuries that were just too severe despite everything we did. Corporal Michael Brennan from Boston, 21 years old, stomach wound from shrapnel. We got him into surgery within 30 minutes, got him stabilized, thought we'd saved him. He made it through the night, made it through the next day. Then sepsis set in, infection spreading through his abdomen faster than we could fight it. Antibiotics weren't enough. Nothing was enough. He died on the third day in the post-op tent, surrounded by other wounded men. I was there when he died, holding his hand, giving him morphine, trying to make it easier. He asked for his mother. They always asked for their mothers at the end. "Tell her I tried," he said. "Tell her I didn't want to die." "I will," I lied. I didn't know his mother, would never meet her, would never be able to tell her anything. He died at 0340 hours. I recorded the time, filled out the paperwork, moved his body to the morgue tent, then went back to work because there were always more casualties, always more boys who needed help. I stopped sleeping well, would lie in my cot hearing phantom helicopters, phantom screams, would dream about making triage decisions, about pointing to the left or the right, about men dying because I'd made the wrong choice. Started drinking, not heavily, not enough to impair my work, but enough to sleep, enough to stop thinking, enough to feel less. Major Williams caught me one night, drinking alone in the supply tent. She didn't report me, just sat down and asked for the bottle. "How do you do it?" I asked her. "How do you keep going?" She took a long drink. "You tell yourself it matters, that saving the ones you can save justifies the ones you can't. You tell yourself the numbers, 97% survival rate. You focus on the successes and try to forget the failures. Does it work?" "No." She handed back the bottle. "But you do it anyway, because the alternative is giving up, and if we give up, they all die." Winter came. The cold made everything worse. Harder to start IVs when patients were hypothermic. Harder to keep wounds clean when everything was covered in frozen mud. Harder to work when your hands were numb inside surgical gloves. The casualties kept coming. Different injuries now. More frostbite, more trench foot, more cold-related complications on top of combat wounds. We treated boys who'd been shot and frozen, who'd lost fingers to frostbite and toes to bullets, whose wounds had frozen and thawed and frozen again. I'd been there 6 months by then, felt like 6 years. I could tell at a glance what category someone fell into, could assess injuries with barely a look, could make life or death decisions in seconds without thinking about it. I'd become efficient, effective, exactly what they needed me to be, and I hated it, hated what I'd become, hated the coldness, the calculation, the way I could look at a dying boy and feel nothing except the need to move on to the next patient. The television show makes it look like everyone bonds, like the unit becomes a family. There was some of that. We relied on each other, supported each other, functioned as a team, but there was also distance, everyone dealing with their trauma privately, keeping their breakdowns hidden, maintaining the professional facade because that's what was required. I had one friend, Lieutenant Sarah Chen, a nurse from California. We'd arrived around the same time, been through the same experiences. We'd talk sometimes late at night when we couldn't sleep, share a cigarette I'd started smoking, and talk about home, about the lives we'd left behind, about what we'd do when this was over. Sarah was good at her job, maybe too good. She never hesitated, never questioned her triage decisions, never seemed affected by the death around us. I envied that, wished I could be that detached. In March 1952, Sarah triaged her brother. Didn't know it was him at first. He came in with the dog tags turned wrong, covered in blood, face obscured by injuries. She'd started the assessment before she recognized him. Private Daniel Chen, 20 years old, IED blast, multiple traumatic injuries, severe head trauma, expectant. Sarah stood there holding her brother's hand, and I saw her face break, just completely shatter, the professional mask falling away, revealing the raw agony underneath. "Captain Sullivan," she said, her voice barely audible. I need someone else to—" "I've got him," I said, gently moved her aside, took over the assessment. He was expectant. She'd made the right call. There was nothing we could do. The head trauma was too severe, the other injuries too extensive. He was already dying, probably wouldn't last the hour, but I couldn't tell Sarah that, couldn't confirm that her brother was going to die, and she'd been right to categorize him as not worth saving. "Get Dr. Morrison," I told a corpsman. "Tell him we need him now." Morrison came, looked at Daniel Chen, looked at me, understood. "Get him to surgery," he said, even though we both knew it was futile, even though there were other patients who needed that operating table more. Now. Daniel Chen died in surgery, never regained consciousness. Died while his sister stood outside the surgical tent, waiting, hoping, praying for a miracle that didn't come. Sarah transferred out a week later. Couldn't stay. Couldn't keep doing the job after that. I heard later she'd had a breakdown, spent time in a hospital, eventually got a medical discharge. I understood. I was barely holding on myself. My breaking point came in June 1952. A year into my deployment. I was due to rotate home in 2 months, just 2 more months. I could make it 2 more months. We got a kid, Private First Class Tommy Rodriguez from Texas, with a sucking chest wound, treatable injury, very survivable if we got him to surgery quickly. He was conscious, scared, but stable, asking about his buddies from the ambush that had wounded him. I put him in the immediate category, got him prepped for surgery, told him he was going to be fine, meant it, he was going to be fine. But then the helicopters started coming, mass casualty, company hit by artillery, 30-plus wounded incoming, and suddenly there weren't enough surgeons, weren't enough operating tables, weren't enough hands. Rodriguez had to wait. Other patients were more critical, needed surgery more urgently. He could wait an hour, maybe 2. He was stable. He was going to be fine, except he wasn't fine. Something happened. Maybe a clot broke loose. Maybe there was more internal damage than we realized, and his condition deteriorated while he waited. By the time we got him to surgery, he was crashing. They tried. They really tried. But he was too far gone. He died on the operating table, a completely survivable injury, and he died because he had to wait, because I'd made him wait, because I'd triaged other patients as more critical. I'd made the right decision. By the numbers, by the logic of triage, I'd made the correct call. Those other patients were more critical, did need immediate surgery. Rodriguez had been stable. The decision made sense, but he was still dead. I finished my shift, went to my tent, sat on my cot, and I couldn't do it anymore. Couldn't make another decision. Couldn't choose who lived and who died. Couldn't carry one more death. I sat there for 3 hours, didn't move, didn't think, just sat. Major Williams found me. "Captain Sullivan, you missed the shift change. You're needed in pre-op." I didn't respond. Couldn't. "Margaret," she used my first name. I know it's hard, but we need you. Those boys need you." "I killed him," I said. "Rodriguez, I killed him." "No, the war killed him. You did your job." "My job is killing people." She knelt in front of me. "Your job is saving people. You save more than you lose. You know that." "Do I? How do I know the ones I save are the right ones? How do I know Rodriguez shouldn't have gone first? How do I know? You don't. Her voice was firm. You don't know. You make the best decision you can with the information you have, and you accept that sometimes you'll be wrong. That's the job. That's what we signed up for. I can't do it anymore. Yes, you can. You will. Because if you don't, someone else has to. Someone with less experience, less training, who'll make worse decisions and kill more boys. You want that? I didn't, so I stood up, went back to pre-op, made more decisions, saved more lives, lost more lives, and I hated every second of it. I came home in August 1952, 14 months in Korea, 14 months of triage and death and impossible decisions. They gave me a Bronze Star, told me I'd done excellent work, saved countless lives, served with distinction. The Army wanted me to stay, to continue my career, maybe become a chief nurse somewhere. I declined, took my discharge, went home to Pennsylvania. My family threw a welcome home party. Everyone was proud of me, wanted to hear stories, wanted to know what it was like. I smiled and said it was hard but rewarding, said I was glad to have served, said all the right things. Didn't tell them about the triage, about the expectants dying in corners, about making life or death decisions dozens of times a day, about Rodriguez and Sarah's brother and Private Cooper and all the others whose names I've forgotten but whose faces I still see. I tried to go back to nursing, got a job at a hospital in Philadelphia, same place I'd worked before. Thought maybe civilian nursing would be easier, would help me readjust. Lasted 6 months, couldn't do it. Every patient I saw, I'd start triaging them. Immediate, delayed, expectant. Couldn't turn it off. Couldn't just treat people normally without categorizing them, calculating their chances, deciding their worth. I quit. Tried other jobs. Secretary, teacher, retail. Nothing worked. Nothing felt right. Everything felt meaningless compared to the life and death stakes of the MASH unit. But I couldn't go back to nursing, couldn't face making those decisions again. I married in 1955. Good man, veteran himself, understood some of what I'd been through. We had 2 children. I became a housewife, a mother, did all the things women were supposed to do in the 50s. And at night, I dreamed about helicopters, about boys on stretchers, about pointing left or right, immediate or expectant, life or death. The television show started last year, MASH. Everyone loves it. It's the #1 show in America. It's funny and heartwarming and shows the medical personnel as heroes. And maybe they were heroes, maybe we were. Maybe saving 97% is heroic enough that we can forget about the 3% we let die. But I can't forget, can't laugh at the jokes, can't enjoy the stories, can't watch it without seeing the real thing, the blood and screaming and impossible choices. My husband asked me once why I can't watch it. I tried to explain, tried to tell him what it was really like. But you saved lives, he said. You should be proud. I let people die, I told him. I chose who lived and who died. How am I supposed to be proud of that? He didn't understand. How could he? He wasn't there. Didn't have to make those choices. Didn't have to live with them. I'm 48 years old now. It's been 22 years since I left Korea. 22 years, and I still can't escape it. Still can't stop categorizing people I meet, wondering how I'd triage them if they came into my tent. Still can't stop hearing phantom helicopters. Still can't stop wondering if I made the right decisions, if Rodriguez should have gone to surgery first, if any of the expectants could have been saved if I'd tried harder, pushed more, made different choices. The numbers say I did well. 97% survival rate, hundreds of lives saved, commendations and medals and recognition. But I remember the 3%, remember their faces, remember their names when I can, remember the ones I chose to let die because someone else had a better chance. That's what no one talks about, the hidden cost of that 97%, the 3% we sacrifice to achieve it. The impossible moral calculus of deciding that some lives are worth more than others because resources are limited and time is short and you can't save everyone. We were heroes, they say. We saved lives, they say. We did the impossible, they say. But we also played God, decided who lived and who died, carried those decisions home with us. The television show makes it look noble, makes it look like we struggled but ultimately triumphed, like every patient gets the care they need, like we're all one big family supporting each other through the trauma. Maybe some units were like that. Maybe some people came through it intact, able to laugh and bond and remain human. I didn't. I came home broken, came home knowing I'd done terrible things for good reasons, came home unable to connect with normal life because I'd spent 14 months living in a world where people were categories, immediate, delayed, expectant, and my job was to decide which category they belonged in. I saved lives. I absolutely saved lives, hundreds of them. Boys who came in broken and left intact, who went home to their families, who got to live because I made the right decisions. But I also chose not to save lives, chose to let boys die alone in corners, chose to prioritize resources, chose survival over compassion. That's the part they don't show on television, the part that's not funny or heartwarming or entertaining, the part where the nurse with the Bronze Star goes home and can't sleep, can't work, can't function because she's carrying the weight of every decision she made. I did my duty, I served my country, I saved lives, and I'm still paying for it, still living with it, still trying to figure out if I'm a hero or a monster or just someone who did what had to be done and got broken in the process. Private James Cooper, Private Rodriguez, Corporal Brennan, Private Daniel Chen, and hundreds more whose names I've forgotten. I see their faces, all of them, the ones I saved and the ones I didn't, the immediate and the expectant. That's what service in a MASH unit meant. That's what no television show can capture. The weight of impossible choices, the burden of playing God, the knowledge that you saved many but sacrificed some, and you'll carry both for the rest of your life. I was a good nurse, maybe even a great one. I saved lives that would have been lost without me. But I'm not a hero. I'm just someone who survived the war and came home carrying all the dead I couldn't save, and they're still with me. Every day, every night, every time I hear a helicopter or see someone in a uniform or watch people laugh at jokes about something that wasn't funny at all, they're with me, always. The 3% that made the 97% possible, that's the real story of a MASH unit. But nobody wants to hear that story. They want the jokes and the hijinks and the heartwarming moments. So I keep it to myself, carry it alone, and try to live with what I did and who I became in those 14 months in Korea. Some days I succeed, some days I don't, but I keep going, because that's what you do when you survive. You keep going, carrying your dead, trying to make your survival mean something, even when you're not sure it does.